Welcome back, everyone. This is Dr. Davis. This is maternity exam number 2, module number 4. This is part 1. I did split this one as it's a little bit longer. So there are 2 parts to this. I wanted to add that I use the phrase physician a lot, or healthcare provider. Please understand that that includes midwives, um, whomever you are seeing, nurse practitioners, um, during your care. Just that's a blanket statement. If I say physician, I don't care if you use a midwife, that's great. Um, I just wanted to state, because I thought about that after I recorded the last lecture, that I use that physician a lot. And what I mean is you need to report that information to whoever the healthcare provider is. Um, so I just wanted to mention that I'm using that interchangeably. All right, so these learning objectives are for both sections of this module number 4. So we're going to talk about transition for baby from intrauterine to extrauterine life, the parts of the assessment, gestational assessment, nursing care for the babies in that first week, lab and diagnostic studies that we're going to do, support of the parents, and any therapeutic or surgical procedures for neonates specifically, and how we're going to take care of them during those. All right, our normal newborn. So the first 28 days of life is considered the neonatal period. Okay, so I'm still a newborn for those first 28 days. My body is still trying to adapt to life on the outside. Because remember, when I'm on the inside, when I'm in an intrauterine environment, mom controls everything. I don't have to worry about my temperature. I don't have to worry about doing the work of eating or being fed, doing any of those things. Okay. And then I have to change from being inside intrauterine to being outside extrauterine. So now I have to adapt to controlling my own body temperature, breathing for myself, doing all these other things that are really important for me to survive. And that takes just a little bit, okay? So in our picture here, remember yesterday I talked about the hugs tag. So you can actually see in this picture, I just wanted to bring it up, you can see that hugs tag laying in the bed right above the baby. That's what they typically look like. That goes around an ankle or a wrist, typically an ankle, just because it's a little bit big and bulky, and you don't want the baby hitting itself with that big bulky thing over and over, right? So we usually put it on an ankle, and it's got one side of the band in. When you loop that around and put the other side of the band into the hugs tag and then pull it tight when it gets contact with that skin, that's how it activates it. So it'll go ahead and put it into the computer system and start monitoring it. So when it's like this, where it's only got one strap in, it's not monitoring anything. It's just laying in the bed. Okay. Other things that are going on here. So baby has a clamp on his umbilical cord. You may see 2 clamps being used. Some places you may see a clamp with a number on it, and that's going to match the ID band number as well, because we want to make sure that moms and babies are connected to the right people. Why do we add now a umbilical clamp with a number on it? Because babies lose weight after they're born. So I'll be born at 7 pounds 3 ounces at lunchtime, but at midnight when I get weighed again, I may weigh 7 pounds. Okay, and that may be a little bit too dramatic, but I want you to understand that a normal baby loses weight after birth, and then it usually takes a week or two for them to get back to their birth weight, okay? And that's normal. So what happens? What does that have to do with anything? Well, when you lose weight, then the bands that were put on for you being at a higher weight are too big, and so they're going to be falling off. So then you've got to put bands back on baby, or one gets lost in mom's bed and gets thrown away. Who knows what happens to these things? So that's why now they're also putting a number on the cord clamp, and that matches baby's ID band and mom's ID band. Okay, so sorry for that digression. I just wanted to go ahead and point those things out while we are talking about moms, moms and babies. Okay, so some of the things I need to do when I convert to outside life, outside of the uterus life, I have to learn to maintain my own body heat. I have to breathe. I'm at risk for infection now. I have to learn to eat. And I also have to, oh, so those are the big ones for mom. Now, as for nurses, what do I need to do? I'm going to have to work with the parents in making sure they know how to care for the baby. So there is a hint on here. I want to talk about it, but I want you to also understand it's not evidence-based practice anymore. So you may see questions that ask about suctioning baby. So we would typically suction their mouth first and then their noses. Just because if you start in the other direction, if baby has anything in its mouth, when you suction its nose, it's going to kind of take a big gasp. And so anything in its mouth is going into its lungs. Okay. So we want to, if we're using a bulb syringe to suction a baby, we're going to suction that mouth first and then the nose. Now, why I say it's not evidence-based practice, this is not being done like it used to be. Okay, it used to be as soon as baby's head was out, the OB would start suctioning that baby's mouth and nose. Now we have moved away from that, and we're not doing a lot of suctioning until baby shows signs that they need it. So if I'm gagging on something, then we'll go ahead and do that. Okay, so newborn measurements. These are some of your normals that we should um, kind of note. I don't feel like you really need to memorize this um, other than our weight there. That would be probably important to know that's a normal weight. So 6 to 9 pounds is a normal weight for babies. They should be about 18 to 20 inches long. Their head circumference should be 13 to 14 inches, and their chest circumference is usually about 12, but typically you'll find that most head and chests are about the same. That's just from years of experience there. So the general appearance when I'm first born, I should be awake, my extremities should be flexed. They should be able to move all their extremities. They should have a strong, lusty cry. There should be some subcutaneous fat, and we'll talk about why that's important. And you should not see any anomalies, no obvious anomalies. By that I mean extra digits. We have lots of babies born with extra digits, fingers and or toes. I won't have any obvious signs of a cleft lip or palate. All those are considered some abnormals. Okay. So one of the things that we're also going to look at, we're going to look at the umbilical cord, and we're looking for one artery and two veins. Okay, so the artery is going to be smaller, the two veins should be larger. Okay, so this discusses the Ballard scale. So this is how we determine how many weeks gestation the baby is for certain. Because you have to understand, remember, unless this baby was conceived through IVF or some sort of fertility treatments where a doctor is implanting an embryo. Um, that way they know exactly when this person became pregnant. It's all a guess. Okay, we're guessing until baby's on the outside. So we can be off up to 2 weeks, one way or the other. So you could think you were 40 weeks and the baby measure at 38, or the baby could measure at 42. So it's just a guess until baby's on the outside. So this Ballard scale is one way that we use to decide the actual maturation score of the baby. So why is this important? So if I have a baby that's supposed to be 38 weeks, but when I complete the scale, this baby's actually 35 weeks, that makes a big difference for our baby because that means that I'm still a little bit premature. So I need to be watching for signs of respiratory distress, not feeding well, um, not being able to hold my temperature, all those kind of things. One thing that you will, and I will say several times, is typically the babies that have a harder time between say a 28-week baby and a baby that is 35 to 36 weeks, between the two of those, the 35, 36 weeker is going to have more problems. And I know that sounds crazy, but for some reason, babies born at 28 weeks are a bit more hardy, and then these babies that are 35 weeks, while they're larger and they should be better off, they usually have a more difficult time. I can't tell you the reason why, it's just something that I've noticed over the years. Okay, so back to Ballard score. So basically what we're going to do is there's a whole list of measurements and some different things with stretching baby out and how are their joints? Are they very flexible, etc. Hopefully this will make sense on our next screen because it has the actual chart to look at. So things I'm looking at is once I decide how far along this baby is, so maybe this baby is perfect 40 weeks, but only weighs 5 pounds. So I'm going to say that baby is small for the gestational age, right? So I'm 40 weeks, but I'm only 5 pounds. I really should be in that 6 to 9 pound kind of a gradient, right? A weight. So same thing for a large for gestational baby. If I have a baby that is 40 weeks again, but weighs 10 or 11 pounds, then I'm going to be concerned that that's a large for gestation baby. So that baby may have some issues, or both babies might have some issues with some blood sugar. So those are babies that we're going to watch a little bit closer. Okay, so this is the actual Ballard scale and what it looks like. So as you look, this top part of it looks a little bit crazy, right? But basically it's asking you, let's look at the first column or row across there is posture. So looking at the baby, it's laying on underneath the radiant warmer. What does that baby look like? What is its normal state? Is it a number 4 where it's flexed like it's supposed to be? Or is this baby like a number 0 where the extremities are just laying flat? Okay. The next one down is called a square window. So basically what they're doing is they're taking the wrist and bending it. And so babies that are full term, that wrist should be able to, that extremity, that wrist joint should be flexible enough that you can actually put the wrist down on the hand onto the arm. And if so, then that baby will get 4 points. If not, if the baby's that joint is not that flexible, then it'll go to one of these others. Basically, I'm going through all of these um, different movements here of this baby, and then I'm going to circle the ones that I get. Then I'm going to add up the numbers in the columns. Okay. Same thing with the physical maturity. I'm going to be looking at what does their skin look like? Do they still have hair? Lanugo. What does the bottom of their foot look like? So I'm going to count up all the numbers, and then if you look at the maturity rating on the right, however many points they get is how many weeks they are. So if I only get 5 points, I'm 26 weeks. If I get 50 points, I'm 44 weeks. Okay, so that's the basic of this Ballard scale. And it still is only an estimate of our gestational age, but it gets us about, as close to saying how many weeks this baby is as possible. Okay, when I'm taking care of my newborn, every baby should have a bulb syringe in their bed, in their bassinet. We need to teach mom and the significant other how to operate that bulb syringe. It's important that you tell them that before you put it in their mouth or nose, that they go ahead and decompress it and then put it in their mouth or nose. Because if not, if you stick it in their mouth and it's not decompressed first, what's going to happen? I'm going to blow air into baby's mouth or nose, and that will actually just push things farther back, right? So it doesn't help. So bulb syringe teaching is real important. Make sure you show them, you squeeze it, then you put it in their mouth, you suction it out, then you squirt whatever fluid came out onto the bedding or on a sheet or something, so you can kind of clean that out and then go back and do it again. Okay. Um, Usually we want babies on their back um, to sleep, but it is possible that if we're having issues with some kind of choking, that bulb suction doesn't work. We're going to sit baby up and kind of lean them over, their face over, and pat their back, trying to get um, that fluid or mucus or whatever is in there out of their mouth and nose. Okay, when we're talking about infection, of course, our number one prevention is hand washing. So anybody who comes in, if we're back to where we can actually come and visit people while they're in the hospital, if not at home, anybody who comes in to visit that baby should wash their hands before they hold the baby. Especially in that neonate newborn state, we don't have a lot of immune system working. So we want to make sure that we're doing that. Cord care, we are going to clean that cord with alcohol every time we change the diaper. Every hospital is a little bit different. There's a ton of evidence where that states that it doesn't seem to matter whether you actually use alcohol on um, cords or not, that they dry at the same rate. So just go with whatever the teaching is that your hospital is doing. Um, Typically, the easiest way for parents to remember to clean that cord is to do it with a diaper change. So just to put the alcohol around the actual umbilicus, because all we're doing is trying to dry that cord up so it'll go ahead and fall off. If baby is having a circumcision, you may use some sort of petroleum gauze dressing, or what we did, we didn't actually use a petroleum gauze dressing. We actually just had little packs of um, petroleum and jelly and just put that around the circumcision site, and then would place a gauze on top of it. And that is just to keep the circumcision from sticking to that diaper. Because, if it still has some oozing or bleeding, and you go to change that diaper without having that extra layer in there, it's possible that when you go to pull the diaper open that has stuck to the diaper, and so that can be very painful for baby. Um, Anybody who's sick should not come see this baby. They should not come to the hospital. They should not come to your house. Especially now with COVID, you want to keep people away. Anybody with diarrhea, open wounds, infectious skin diseases, or a active herpes virus, meaning like cold sores, you do not want them to come and visit your baby, nor do you want them to kiss on your baby. We also want to, of course, encourage breastfeeding because it does increase the immune factors for the baby. Okay, so something else that you may see in a newborn, which is totally normal, is acrocyanosis. So acrocyanosis is where the hands and feet are blue. Um, so why does this happen? It happens because my environment is now cold. Um, I'm used to being in a nice 98-degree temp environment, right? And then I come out, and most of us do not prefer to live in 98 degrees. Typically, we have some sort of air conditioning on, so it's cold. Another reason is my peripheral circulation is not well established yet. Um, Remember when we talk about fight or flight, what happens to the blood in your body? Where does all the where does all the blood go to when you're in a fight or flight situation? Does it go to your hands and feet, or does it stay kind of shunting to your major organs and brain? Um, so during your fight or flight, it goes to the trunk and to your brain, right? Because those are the important parts. I can live without arms and legs. I cannot live without a brain or other organs, correct? Same thing here. So it's important that my trunk is pink and my head is pink, and then my hands and feet are the last things that I'm going to worry about getting circulation to. So it's perfectly normal. Some babies, it's way more dramatic. This baby, you can't see it as much in. You can tell its hands are a little pale. Its feet are a tinge blue. Um, but that is all normal, okay? Now, circummoral cyanosis. So if you see blue around our lips or very pale around our lips, then that is something different, okay? That's telling me that I'm not getting great respiratory oxygenation, sorry. Um, and so I need to do some more crying, maybe a little bit of oxygen. Now, if it's, say, day number 2 of baby's life, or it's been a full 24 hours and I'm seeing circummoral cyanosis, then I'm concerned there's some sort of a heart anomaly that I need to check out, okay? Babies with chronic heart disease or congenital heart disease usually do fine those first couple of days. Um, Typically, babies with congenital heart disease will go home and then have some sort of event that will cause mom and dad to have to call 911, bring baby back to the ER, okay? Um, because it takes a little while for those anomalies to kind of kick in. It's still in that fresh kind of newborn period, and I'm doing okay. I'm maintaining well enough that there's no obvious signs, but then I go home and really have some sort of an issue. One of the next things we might see are called Mongolian spots. So if you see in this baby over here on the right, it looks like what you would think was bruising on this baby, but it's actually called a Mongolian spot. It's just a bluish discolored area on the lower back or buttocks. Sometimes I've even seen it on the back of their thighs. Um, This is pretty big Mongolian spots. Sometimes it's just very small, round areas, but you're going to see this more on any dark skinned baby. So African American, Asian, Hispanic, Native American babies, anybody with a darker skin tone may have these Mongolian spots. Um, we do go ahead and document that there are some Mongolian spots. Um, you initially, the parents, if they've not seen this before, will think that the baby is bruised. So you'll need to tell them that those are just Mongolian spots, that eventually they will resolve. They're supposed to resolve by about school age. I know I've had some of my students in the past say that their children still have them even at school age, but they have faded quite a bit. So it's just one of those normal things that you may see on a darker skinned baby. Okay, so milia is also something normal that you may see. They're just the white papules on the face. Usually you're going to see them on the nose and chin. Sometimes they'll have them right next to the nose on the cheeks, but usually it's the nose and chin. All right, those are just sebaceous glands um, that have some fluid still in them. Some parents say, why do they have like little white heads on them? They don't need to pick at them, just leave them alone. They'll resolve. It's just normal kind of newborn skin. You may also hear these called milk bumps. So that's another term that some families will use. So if you hear it, that's what they're talking about. Okay, so in this baby, and on this picture, you can see the little white bumps on the gums of the baby. So these are called Epstein's Pearls. Sometimes those Epstein's Pearls can be farther down on the gums to where they actually look like little teeth. Um, those are also benign. They will go away in a few weeks. There's not really anything to do with them. It does look a little interesting if they're farther down on the gum. Um, and it looks, you can actually see it looks like little teeth in there. So it can be a little frightening to the parents and surprising. So make sure that you just tell them that those are normal and they're going to go away. All right, so the last little bit of these slides, about the next 6 slides or so, are newborn reflexes that we should see. Um, so we're going to go through each one of those, and then I have some videos in class we'll go through so you can actually see um, what these look like in your baby, these different reflexes, okay? Um, So our first one we're going to talk about is the Moro reflex. So this one is present at birth. It disappears by 6 months. So you won't necessarily see it. This is that startle reflex. Okay, so that's if baby's sleeping and I touch them, their arms may kind of wave in the air. Um, if you've not seen this before, the video I have will show you all these different things. But of course, you can always YouTube Moro Reflex in newborn, and there'll be tons of videos so you can kind of see what this looks like in a baby. Um, our next part that is mentioned is that the baby makes a C shape with a thumb and index finger. Um, I have never, that's not something that I was taught before, but it is mentioned, so I'm mentioning it. The big part of this reflex is the startle, okay? So this reflex, you may see some babies have what I call an exaggerated Moro reflex, meaning all I have to do is unwrap their blanket and they start this shaking of their hands. And startling kind of a thing. So it just depends on the baby. I've also had babies that don't have as big of a startle reflex. So sometimes, you know, just bumping the crib, um, and a normal baby would really give you a nice little startle reflex. Some babies don't. So we have to kind of watch that and see what is going on. Now, just because this is a great picture and I'm noticing it, look at baby's head here in this picture. Can you see that ridge in the hairline there? So you've got the forehead and then a little puff of hair, and then there's kind of a ridge. So that is where the sutures in that head are kind of overriding a little bit. That is also normal. The head is made to do that. Those sutures are supposed to override, but I wanted to mention it while we were on this screen. That way, when I talk about it later, you also have this as an example. Okay, this next reflex is the tonic neck. So this one is also called the fencing position. Basically, what it's saying is when you lay a baby down, um, whichever way their head is facing, especially if it's on the side, the one arm will go straight, the other arm will come up behind its head. So if I turn my baby's head and make it look the opposite direction, then I'm going to switch those arms. Okay. Um, so that is one of those reflexes. It should disappear by 4 to 6 months, but typically you're going to see it a lot more between birth and 6 weeks. It should be completely gone after 6 months. If it's still there, then there may be some issues with some cerebral palsy or something else going on with your baby. Okay. Okay, so our rooting reflex. This is the reflex that helps baby in feeding. So um, basically what it is if I'm going to touch near baby's mouth, that baby's going to open its mouth wide and try to find that nipple. Okay, so that's what it's doing. It's looking for food. Okay, so anytime that you do that kind of rooting reflex next to your newborn baby, you should see baby open their mouth nice and wide so that you can get them attached to the breast. That's the whole idea of this reflex, okay? Um, so that'll kind of help if it's time for baby to eat. Now, this will also happen with a bottle feeding baby. You can still use the bottle nipple to touch next to the baby's mouth, and then they even sometimes kind of like shake their head back and forth trying to attach to that nipple properly. Okay, so you may see that as well. All right, so the sucking reflex. So this is usually um, a reflex that you're going to see at birth, and it should disappear by 10 to 12 months. Basically, it is if you put something into baby's mouth, they should try to suck on it. Okay, so typically, as nurses, part of our assessment is when we have our gloves on, we'll put a finger in baby's mouth. We're checking for a couple of things. We're checking for, does this baby have a suck reflex? But we're also feeling the top of that um, the roof of their mouth to make sure that palate is closed and I don't have any cleft up there. Okay, so those are a couple of things that we're checking when we check to see if there is actually a suck reflex. Now, if baby is premature, you may see a weak or absent response, or if there was some sort of neuro damage or a neuro defect, you may not see a good um, suck reflex, or you may not have one at all. So that's what we're looking for when we're looking for this reflex. Okay, the palmar grasp reflex, this is going to disappear at 3 to 4 months of age. Um, Basically, it is just if you put your finger in the palm of baby's hand, it's going to grab it. Okay. Babies should grab it rather tightly. The thing is that babies, once they grab it, they can't let go, okay? Um, so they will hold very tightly. What this is telling you is if you do this palmar grasp in both hands, so at the same time, you can actually lift baby up into a sitting position just from holding on to their fingers. They hold on that tightly because they can grasp, but they can't do the other half of that, which is open their hand and let go. Okay, so that is also present at birth, and it should disappear when they're 3 to 4 months old. Okay, this one is also the same. So if you put your thumb right underneath their little toes, babies will try to grasp with that toes, um, your finger, whatever is underneath of there. So that will also disappear at 3 to 4 months. Okay, guys, our last reflex is the Babinski. This is present at birth and disappears at 1 year of age. When you stroke the bottom surface, the baby's toes should hyperextend and fan out. Remember, in adults, when we do this Babinski, they should do the opposite, right? The toes should curl in. So this will last till they're about a year, and then it'll switch to the opposite reflex.